So if we think about the historical but still completely applicable reasons for neoadjuvant chemotherapy, obviously we all know, inflammatory breast cancers, patients with inoperable breast cancers, people that have locally advanced breast cancers that you're really trying to improve resectability and offer them some local regional control. And when we look back at previous studies that have looked at the benefit of neoadjuvant therapy versus adjuvant therapy, we can see that in the past we felt that the overall benefit as far as overall survival has been shown that it's equivalent if you're looking at those two options. And this is a meta-analysis looking at 9 trials that was published in peer-reviewed literature, and it was included about 4,000 patients. Most of those patients were from the NSABP 18 trial. And if you can see that the meta-analysis really did not show a significant difference between adjuvant or neoadjuvant arms as far as death or overall survival. If you look at NSABP 18 alone in the 16-year follow-up, that's about 1,500 patients. They were randomly assigned to AC, and that was either preoperative therapy versus postoperative therapy. And again, their overall survival, their disease-free survival, and relapse-free survival really did not differ in those survival curves. So obviously, though, there's obviously been a trend toward neoadjuvant chemotherapy for breast cancer patients. So what is kind of pushing that trend? And that trend is really driven by a pathologic complete response. And when you look back at the NSABP 18 trial, if you were looking at patients that received AC versus in the preoperative setting versus in the preoperative setting who had a pathologic complete response versus patients that did not have a pathologic complete response, you do see a difference in the survival curves in those patients. And the same holds true when you look at NSABP 27. That was with the addition of Taxol therapy. Again, that was all in the neoadjuvant setting. And so if you look in that setting, if those patients can achieve a pathologic complete response, then they do have a difference in their overall survival. And addition of Taxol did increase the number of patients who were able to achieve a pathologic complete response. If you look at some larger meta-analysis, this is a meta-analysis that's an international meta-analysis that includes 12 trials, over 12,000 patients. And they look at patients that either achieve a pathologic complete response versus patients who do not, and their event-free survival and their probability of overall survival. And again, you can see that there is a difference in those survival curves. And for this, the pathologic complete response is really being defined as complete eradication within the breast and in the lymph nodes as well. So if we look at a case, if we have a 46-year-old female who had a mammogram 4 months ago that was completely normal, but now she has a 3-centimeter palpable mass at 1 o'clock in her right breast. Obviously, she underwent mammogram and ultrasound and then ultimately underwent biopsy, and that showed a triple-negative breast cancer. She had a suspicious lymph node that was biopsied and found to be negative. And so we think about kind of the next steps for this patient. Obviously, since she's young, she needs a genetic evaluation. I also think she would benefit from an MRI since she's young and tends to have more dense breast tissue. But then you have the question of, should the patient undergo neoadjuvant chemotherapy or should she undergo surgery first? And so thinking about the benefits of neoadjuvant therapy, I think there's a lot of potential benefits, especially for this patient. Kind of the biggest risk to these patients is obviously distant recurrence. And so the biggest risk of the patient is instantly treated first. So they're able to get systemic therapy that treats obviously their entire body plus their breast or axillary involvement. And for these patients, there are a lot of really good clinical trials, especially for triple-negative breast cancer patients. And so that gives them the option to undergo clinical trial enrollment. Allows time for genetics, and then it also just allows you as the practitioner to be able to assess whether they are having a clinical response. Obviously, if they're not having a clinical response, then it allows you to change therapies and try to tailor that therapy to actually get a response to chemotherapy. A lot of times these patients can be better breast conservation patients in the long run, especially if their genetics are negative. And then ultimately can determine if that patient is able to obtain a pathologic complete response at the time of surgery. And that gives you information about the overall prognosis for the patient, and it also helps inform you and how you need to survey this patient kind of going forward. I think it's important for us to realize that there's difference between tumor subtypes and how we can respond or how we can evaluate their response to therapy. And this was I think, a very interesting study looking at neoadjuvant chemotherapy in the I-SPY 1 trial. And this showed that there is a significant concordance between patients that have triple-negative breast cancers and HER2-positive breast cancers, and then that more solid type phenotype that you see on these MRIs versus MRIs with a more kind of diffuse infiltrative pattern. And that obviously helps kind of inform our decisions when we're starting to think about surgery and what kind of surgeries we can offer them. So that we know that if they have an MRI after neoadjuvant therapy and that tumor was more solid, it was a triple-negative cancer, we can really more reliably rely on that MRI to help us guide our surgical plans. So again, if we look at that same pooled analysis or where they looked at 12 international trials, again, almost 12,000 patients, we can see that there really is a difference in patients and how the pathologic complete response they have based on their tumor subtype. For patients that have hormone receptor positive disease, obviously those patients have a lower pathologic complete response after neoadjuvant chemotherapy, but our patients that are our triple negative patients, our patients that are HER2 positive that undergo trastuzumab therapy, obviously they have a very significant pathologic complete response, which is, can be very helpful as far as prognostic information for those patients. Again, looking at the Alliance trial, a prospective multi-center clinical trial here in the U.S., they were looking at the difference between tumor subtype, so triple-negative breast cancers, HER2-positive breast cancers versus hormone receptor positive. And again, we can see in that final column, the pathologic complete response from the breast and the nodes is obviously significantly better than those patients that are HER2-positive breast cancers patients. And those patients are obviously more likely to be able to undergo breast conservation therapy in the future as well. So again, looking just at triple-negative breast cancers, we see that patients that have a triple-negative breast cancer that do actually undergo a pathologic complete response, their distant recurrence at 5 years is less than 10%, which is equivalent to other subtypes of breast cancer. Conversely, if the patients do not achieve a pathologic complete response in those triple-negative patients, they're much more likely to develop a recurrence and much more likely to die. So on to our next case. We have a 68-year-old female with a right breast mass. It was palpable to her, and that's how she initially presented. Her ultrasound ultimately showed two masses that were side by side at both 8 and 9 o'clock. You can see, this isn't the best picture, but you can see based on the ultrasound, the total span of disease was about 4.6 centimeters, so about almost 5 centimeters worth of disease there. The biopsy actually showed IDC grade 2. It was hormone positive, but also HER2 positive. She also had lymph node involvement, and she desired breast conservation therapy. So we look at the great gains that we've made in these HER2 positive patients. We know that trastuzumab has been well in play now since about 2005, and we've seen a significant improvement in our patient survival due to that. But now there's the potential for dual therapy for HER2 positive cancers. And Perjeta or pertuzumab received accelerated approval in the neoadjuvant setting in 2014. Previously, it had been only approved for metastatic patients. But as you can see, for patients that had T2 or N1 disease, the pathologic complete response was significantly improved in patients that received dual-targeted HER2 therapy, so trastuzumab and Perjeta as well. And you can also see that the 5-year progression-free survival was improved for that group as well. So of course, the pathologic complete response was associated with a longer progression-free survival. So really for these patients, you know, it's Perjeta, pertuzumab is approved for the neoadjuvant setting and the metastatic setting. So if they don't get that therapy up front, there is really not an opportunity for them to get that, and so that's a missed opportunity for that patient. So I would suggest that maybe we should have a new paradigm. You know, in the past we felt like all neoadjuvant chemotherapy patients are equivalent to adjuvant, but I would suggest that there are probably some subsets where one approach is superior to the other. And I would say that that was really for our triple-negative patients, our HER2-positive breast cancer, and even some of our high-risk ER-positive patients as well. So the surgeon's role is obviously still very important in this setting. Typically, the surgeon is the first patient that the patient sees after a diagnosis of breast cancer. And so if the surgeon is not thinking about the potential for these neoadjuvant therapies, then a lot of times that's a missed opportunity for those patients. And it allows you as the surgeon to be able to follow their response, and then obviously they could potentially then be a breast conservation treatment patient as well. Obviously, there's some considerations when you're thinking about breast conservation for those patients, and obviously all the residual disease should be resected. The target volume does not have to be the pre-chemotherapy volume, but just the post-chemotherapy abnormality. So again, looking back at who should receive neoadjuvant therapy, and the same, some of the same patients that we saw earlier, inflammatory breast cancers that are inoperable, or very large stage 3 operable breast cancers. But also I would say that, even some are lower stage if we're trying to convert them to breast conservation therapy, and then obviously our triple negative and HER2 positive breast cancers.